Morning, everyone. We are going to give folks another minute or so to join us. So thank you all for coming. We'll get started in just a minute. Okay, let's go ahead and get started. Morning, and thank you to everyone for joining us today for our webinar, Trauma-Informed Advocacy, Practical Tools for Working with Vulnerable Populations. Quick plug before we get started, if you are a tweeter, please join us at HMPRG or hashtag ILACES. Let us know what you think, and please tweet throughout the broadcast. My name is Madison Hammett, and I am a policy analyst with the Illinois ACEs Response Collaborative at Health and Medicine. And we are so excited to have Sarah Hess of Legal Counsel for Health Justice join us today.
Hello, hi everyone.
I know we have some new people from all over the country in the audience. So for those of us who don't know us, Health and Medicine Policy Research Group works to promote social justice and challenge inequities in health and healthcare. We're an independent policy center in Chicago that conducts research, educates, and collaborates with other groups to advocate policies and impact health systems to improve health of all people. This webinar in particular is put on by the Illinois ACEs Response Collaborative. Health and Medicine is the lead convener of the collaborative. We're a multidisciplinary group that utilizes the science of ACEs and childhood trauma in an effort to create transformation to policy and practice aligned with current research. The collaborative is a backbone organization, so we mobilize, convene, and advocate to create systems-level change. You can visit our website for more information. It includes policy briefs, environmental scans of trauma-informed programs and health departments. And you can also find all of our past webinars and sign up for our newsletter. We'd like to thank the following funders who support this series: the Illinois Children's Healthcare Foundation, the Otho S.A. Sprague Memorial Institute, the Intelligent Community Initiative, the Prince Charitable Trust, and the Albert Pick Jr. Fund. We will have time for questions at the end, so please feel free to type in your questions to that little chat box on the side of your screen throughout the webinar, and we'll get to them. And then after the webinar, you're going to receive an evaluation survey, ways to participate with us at the collaborative, links to the website and the policy briefs I was talking about, as well as a recording of this webinar. To get to the meat, I am so excited to introduce Sarah Hess, our speaker for today. Sarah is an attorney who joined Legal Counsel for Health Justice in 2016, where she serves young people and their families with the aim of mitigating the causes and consequences of trauma, toxic stress, and the social determinants of health. Sarah provides civil legal services through the medical legal partnership model, where she trains health providers to recognize their patients' legal issues and then works collaboratively to solve those problems. Previously, she was a Skadden Fellow at the Chicago Lawyers Committee for Civil Rights, heading a medical legal partnership for school-based health centers at Erie Family Health Center. She also provides training for trauma-sensitive practice for lawyers and other helping professions, including the 2017 Illinois Legal Aid Advocates Conference, Equip for Equality's Disability Rights Consortium, and continuing legal education approved courses at the Chicago Bar Association. And I am so excited to introduce Sarah, and I'm going to switch it over to her and let her present for y'all.
Wonderful. Thanks, Madison. All right, I'm going to show my screen here and jump in. So welcome, everyone. Thanks a lot for attending. Again, my name is Sarah Hess. I'm a staff attorney at the Legal Counsel for Health Justice, and we're here to talk about trauma-informed advocacy. I'm a lawyer, and I'm going to talk about my legal organization, but this presentation is not geared only towards lawyers. It's really focused on folks in the helping professions. So we're going to talk about, I said I'll introduce my legal organization, and then we're really going to talk about the behaviors that we see in adults and children who have trauma histories, and we're also going to talk about that in the context of us as helpers inside the notion of empathic distress. Then we'll focus on the practical tools, right? The meat of the presentation today is the how-to in providing trauma-sensitive advocacy. And then we'll close with practical tools for protecting helpers. We have found, especially through the Illinois ACEs Response Collaborative, that when we talk about trauma of patients or clients, we really always need to be talking about empathic distress and the trauma that helpers themselves experience. So first off, I work at the Legal Counsel for Health Justice. We use the power of the law to secure dignity, opportunity, and well-being for people challenged by chronic, disabling, and stigmatized health conditions. This is our 30th year anniversary, so we're celebrating all year long. And we really focus on different collaborative partnerships to provide health justice or to work towards health justice for our clients. So a little bit about that. We do a number of different direct legal services. So we provide civil legal aid through three different projects here at Legal Counsel. I work in the Children and Families Project, and we mostly provide services through the medical legal partnership model, which I'll explain in a little bit more detail. But at base, we work with all different kinds of medical providers to treat their patients. We also have the SSI Homeless Outreach Project, which focuses on adults experiencing homelessness with co-occurring mental health and substance use disorders. And we actually employ the medical legal partnership model to some of those, to create partnerships with homeless shelters. So it follows the same idea that I'll talk about in a minute. And then finally, we have AIDS Legal Counsel, which has a daily open intake for anyone living with HIV or AIDS on any issues that folks are facing. And then we also have a unique medical legal partnership with Howard Brown Health, which serves a very high client population living with HIV. We also focus our work around identifying systemic problems while we provide those direct one-to-one legal services. And so we try to affect systemic change through class actions and policy advocacy to improve legislation or regulatory rules and things like that. So one of our crown achievements is that we were able to keep Medicaid running during the state budget impasse in Illinois when we just didn't have a budget for a couple of years. And doctors were threatening to stop treating children on Medicaid because the state wasn't passing federal funds on through to the providers. So you can see this list in this webinar. I think is going to be available to you if you want to read more about our work. And then on the legislative side, last year we had a win in terms of passing legislation that allows schools to stock asthma rescue medication for students who have yet to be diagnosed with asthma. So if a kid is having an asthma attack in school, it's not a matter of putting that kid in an ambulance and sending them to the hospital, but that you can treat them on the spot with life-saving measures. So I mentioned medical legal partnership, and MLP really came out of a public health model and effort to address the social determinants of health. And so you can see on this flowchart, we train medical providers of all different kinds, from care coordinators to home-based, home-visiting community health workers or medical residents, and we train them to identify health-harming legal needs. So we'll provide an overview training on medical legal partnership and how it works, but then we'll drill down, for instance, on special education issues or the rules behind Social Security SSI benefits for children with disabilities, so that those providers can identify when their patients are having a legal problem that's going to make it hard for them to get healthy or stay healthy, or for their family to have financial stability. Those providers then refer those patients to us the same way that they would refer a kid to go see a cardiologist, and we provide direct legal assistance. So we're providing legal care. And then we also hope to transform clinical practice through those first two phases, identifying areas where we can make the job of the provider a little bit easier. So things like creating template letters for a doctor to initiate the IEP evaluation process to get their patient with a disability special education services. You don't always need a lawyer to get that started, but when you put that kind of onus on medical providers and they don't have the tools they need, it becomes really onerous, it becomes really hard to manage, and impossible when you're thinking about the short visits that many providers have with their patients. So we aim to transform clinical practice through those lessons. And then finally, we hope to improve population health. So coming out of a public health model, this is really about upstreaming from what we see as problems in our direct legal services to trying to fix the systemic barriers that are making it hard for people to access the services they need, or to continue to stay eligible for Medicaid, for instance, or Social Security benefits. So we do this, like I said, in a number of there are many different manifestations of this. So now we've got partnerships with homeless shelters. We're starting a new pilot with an early childhood provider and an early intervention program. And then we've got all the different versions of federally qualified health centers and children's hospitals and care coordination programs. So it's a really fantastic model for addressing the social determinants of health in a way that's flexible to whoever your partner is going to be. And if you're interested, I'll just point at the bottom of this slide to the National Center for Medical Legal Partnership, which has fantastic resources on this. Okay, so let's jump in. We're here to talk about trauma, so always good to start with a baseline. And I like this definition. There are actually several definitions for trauma, but I think this one gets to what's really relevant to how we provide help, and I'll talk about why. But first, trauma is something that threatens or harms the physical or emotional integrity of an individual or someone close to them. Importantly, it overwhelms the ability to respond, and it results in adaptations that create significant difficulty in functioning. So the point behind this is that just because someone has experienced a traumatic event does not mean they are traumatized, right? So I've been in a couple of car accidents in my life, but I don't consider them to be traumatic experiences in that I have not been permanently traumatized by those experiences. I don't, for instance, have a paralyzing fear of getting in cars going forward. I don't avoid cars and take buses all the time. We're here to talk about things that are so extreme in terms of the experience of them for the person who experienced it that it overwhelms the ability to respond, and it results in lasting adaptations that change people's behaviors or their level of functioning. So I'm not going to dive into the science, particularly the social science behind this, but it is good to know that a lot of this field came out of the Adverse Childhood Experiences study, which happened in the late 90s, early 2000s, and it really began with a hypothesis that when kids experienced particular adverse childhood experiences like abuse, neglect, major household challenges like having an incarcerated parent or domestic violence in the home, they narrowed it down to 10 categories and studied it and found a dose response. So they found a one-to-one correlation that says that when kids have a higher number of these adverse childhood experiences, they also have a much higher likelihood of negative health outcomes in adulthood. And that study was focused on things that they could control for. So they focused on the issues I mentioned taking place in the home: abuse, neglect, and household challenges. Since then, a lot of studies have confirmed the science behind this. So there have been studies that show a link between trauma and insulin production, and they've tied it to type 1 and type 2 diabetes for children. They've tied it to a number of different health outcomes in terms of things like cardiovascular disease and cancer, diabetes and asthma, and then also to a lot of different risky behaviors. So the higher number of ACEs, the higher the risk of becoming a smoker, a heavy drinker, engaging in risky behaviors like taking painkillers to get high, or certain social problems as well. And all of that really roots what we're talking about today, but it doesn't fully address what we're talking about today, because that study really looked at what happens in the home. And so at this point, I really try to talk more about trauma than ACEs. Although if you're familiar with this, you hear people talk about ACEs all the time. But I think it's a fairly limited way to talk about it. And when we think about trauma, looking at this slide, looking at this infographic, we really should be thinking about adverse community environments as much as any of those specific adverse childhood experiences. So the effects of poverty and racism and discrimination, for instance, can have very traumatizing impacts on communities and individuals. And then going down another layer, you'll see adverse collective historical experiences. And I read a quote from Maria Yellowhorse Braveheart that I think is really striking and gets to the heart of this idea, which is that cumulative and psychological wounding over the lifespan and across generations, emanating from massive group trauma experience. So of course, this is very significant to our American history, and something that we should always keep in mind when we're talking about trauma and how to serve clients who have had traumatic experiences. So this is as science-y as this presentation will get. And this is a great graphic that's been developed by the Illinois ACEs Response Collaborative, and it really simplifies the effects of trauma on people. If you do want to know more about the neuroscience behind all of this, there are other fantastic webinars that the collaborative has produced that are available on the website, and you can go back and watch those. I'm just trying to give us a little bit of background before we dive into the practical how-tos. And so I like this slide, or this graphic, to keep it simple. So you can see at the base of the graphic the red section, the red brainstem here, which is focused on the survival state. And that portion of the brain is really just asking, am I safe? It's a yes or no question. There's no judgment involved. There's no analysis involved. Then you rise up and you see this blue section in the middle of the graphic, which is where the emotional state is going to be dictated. It's also in control of the limbic system. And this is asking a deeper and more refined question, which is, am I loved? So beyond am I safe, am I loved? Do I have human relational connections that keep me feeling safe and regulated? And then finally, you see this green portion, the cortex, which is really the thinking brain. So this is where analysis happens. This is where we make meaning of things. And this is where you're going to think clearly or not clearly. This is also the executive functioning portion of the brain. And for our purposes today, the point here is that when someone who has been traumatized is re-traumatized, for example, the red portion of their brain, the brainstem, is really going to take over and dictate what happens after that. When that happens, the connection to the rest of the brain, especially to the green portion, the thinking brain, becomes really tenuous, right? The red brain, the brainstem, is in charge. It's all about survival. There's not a lot of meaning-making going on. The blue section is kicking in to help the person stay safe or get safe. So it's the blue portion that's going to tell your pupils to dilate and your blood vessels to open. And it's going to help you breathe more heavily so that you can take in more oxygen, so that if you need to run or fight, for instance, your physical self is ready for that. I'm just going to mention a couple of things to pique your interest here. when someone is experiencing a traumatic event, there are many different things that are happening in the brain to keep that person safe, right? It's a survival moment, fight, flight, or freeze may be taking place. And when we work with clients who have been traumatized, it's helpful to understand some of the things that are shutting down during that time in the brain or that are firing extra. So I'm just going to give you a couple examples. So one that I find really compelling is Broca's area, which is in the left frontal lobe. And it's a section that when someone is experiencing trauma may get entirely shut down. So the speech center can be disrupted because, of course, when you're trying to survive something, it's not of ultimate importance that you can speak while doing so. And so in an effort to conserve energy and to provide focus, the brain is not, the speech center, I should say, is not firing during that time. And then the result of that can be that someone who experienced a traumatic event maybe isn't able to put words to the event. And we see this a lot in our work. I'll be interviewing a client, trying to ask them what happened in a particular event, and they have a hard time describing it. And that may be because when they were experiencing it, they literally didn't have the capacity to put words to it. I'll mention one more. So Brodmann's area is an area that when folks who've been through a trauma have volunteered to go through an MRI, for instance, and be re-triggered on that trauma, Brodmann's area is an area of the brain that lights up as if the person is literally reliving their prior experience. And the reason for that is because the visual cortex first registers images when they enter the brain, and the visual experience of trauma is emphasized. And when you think of survival, it's important that you can see your surroundings and take in what's around you, and not only what's around you, but details like the facial expression of people around you that your brain is going to interpret as either safe or unsafe. And typically, normal memories will come in through that visual cortex, but then be moved out to other parts of the brain, essentially for storage or for meaning making. So understanding what you saw and then interpreting it later. But with trauma, it may stay in that visually first experienced area. And so when someone is reliving a trauma, they may actually be having the same visual experience that they did during the trauma. Importantly, the timekeeping area of the brain often also shuts down during a trauma. And so if someone is reliving this visual experience, and they're actually reliving it because these memories have not been moved out of that first experienced area, and their timekeeper is shut down, it's a true statement to say it feels like this is never ending and it will never end. And so these are just a couple of different ideas to give you a sense of the way that someone having experienced a trauma and re-experiencing a trauma may not be able to give good information, for instance, about how it happened or the chronology of what happened, but they may also re-experience it in a way that they can't describe. There's a whole lot more really interesting science on this, and I always point people to a book called The Body Keeps the Score by Bessel van der Kolk. And right off the bat, he digs into these issues, and it's some really compelling information about how people process information during a trauma. So all of this, it's important to keep in mind while we talk about this, because it can seem kind of doom and gloom, and that folks who have had prior traumatic experiences are doomed to re-experience them over and over, or to have negative health outcomes. But what's really important to remember is that risk factors are not predictive because of protective factors. So just because you had an experience does not mean that you will also have a predictable result. People who have experiences that are traumatic but also have strong family and friend networks around them may have greater resilience. They have protective factors that can make a traumatic experience just a traumatic experience and not traumatizing, which is an important factor as we talk through these. And then this is just a couple of images because I think it really helps us understand when the brain is in charge, when the brainstem is in charge, when the survival state is dictating what's going on, versus when that green thinking cortex area of the brain is in charge. And here you see the rational brain and the emotional brain are working together. People feel regulated, they feel safe. But when they've been triggered or when their survival state is taking over, it's much more like this. That bucking bronco is in charge. There's no amount of negotiating or trying to convince that bucking bronco, or in this case the brainstem, to calm down rationally, right? There are techniques, and we'll talk about them, that can work towards calming. But I think this is a good way to think about when you're working with a client who is really traumatized, who is also behaving in a way that maybe seems disproportionate to what's going on, or seems overly excitable or hypervigilant, that they may not be fully in control of their behaviors at that moment. And so reasoning is maybe not the way to get folks to calm down. So some of these behaviors or symptoms can be categorized as anger or depression, unexplained physical symptoms we see a lot in our practice, high risk and impulsive behaviors, an inability to de-escalate, which goes to what I was just mentioning. So someone who's really riled up may have a hard time calming down even when the thing that was upsetting has ended or passed. Substance use and alcohol use, we talk about this in the context of self-medicating, try to use judgment-free language, which we'll talk about. Aggression and self-harm can also be common symptoms, and then finally alienation and social withdrawal. So in the SSI Homeless Outreach Project here at Legal Counsel, we see a fair amount of folks with unexplained physical pain, or who are also using controlled substances to literally medicate the feelings away, the feelings of anxiety or depression or fear. And it can be a really effective coping mechanism, but also it makes it harder to get SSI, for instance. And so in that project, the legal arguments come down to showing that childhood trauma typically results in substance use, for instance, and that shouldn't be a bar to being eligible for benefits. So I just mentioned it as one of the ways that we use trauma in our practice, not just to be trauma-informed about what our clients are going through or experiencing, we actually also use it as the base of our legal argument. And I do want to say that what all of this means is that when people have a trauma history, it doesn't mean their brain is broken. The brain is incredibly adaptive. It's changeable, it's malleable. But what's important is that it means that when someone has a trauma history, it means that because of what they've been through, they deserve a little more support and understanding if they need it. And the same is true for kids. But symptoms may look a little bit different. So we do see a lot of children who may be difficult to soothe or seem to be chronically aroused. They may have nonspecific or generalized fears, a sense of a foreshortened future. I work with a lot of teenagers, and I've had a lot of teenage clients say to me, "What's the point of any of this? Just leave, just stop trying." And in those moments, I'm reminding myself, this isn't necessarily that this student wants me to go away or wants to stop working with me. This may also just be a symptom of their inability to see that things can get better or that they have a future. We also see a lot of difficulty with peer relationships. So when you think about a kid who has been through a lot of trauma, is maybe hypervigilant. They're always aroused. They're waiting for the next attack. They're waiting for the next thing to go wrong. They're waiting for the people around them to fail them. They're going to be proven right in some of those instances, and it's not going to go well. And so trying to create situations where kids can build strong relationships is one of the things that we try to create to combat the effects of trauma and toxic stress. We see a lot of impulsive behaviors in child clients, inability to recognize danger or consequences. We've had a few cases now with pretty young kids, 7 or 8 years old, who pretty regularly run out into traffic. And not for what adults would call suicidal ideation or attempts, but because they really don't see the danger in front of them. Their sense of danger may be dictated by their experiences, which have nothing to do with cars or busy streets. So the idea behind all of this is also not to try to diagnose the kids that I work with. The idea is to look at their behaviors through this lens and understand that there may be a trauma context for those behaviors. And so treatment for those behaviors may be very different than, for instance, a psychological diagnosis that doesn't have anything to do with a trauma history. So it's more about context for people's behaviors. And then finally, stranger anxiety or indiscriminate attachment can be a symptom. In working with little ones, I've had like toddlers and really young kids sort of latch on to me having never met me before. That's not because I'm so attractive to kids, right? That may be because that's a moment of safety for them, and one of their protective mechanisms is to latch on to people, whether they know them or not. So what does this mean for us, right? Those are some of the behaviors that we see in adults and kids. And you'll see here on the helpers and empathic distress slide, the list on the right is exactly the same as the adult list, right? All of the things that may manifest in folks who've been through trauma are the same ones that manifest in helpers. I included a couple of definitions here on the side as well, because as helpers experience empathic distress, they also can, of course, experience burnout, so physical or mental collapse from overwork, compassion fatigue, right, a decreasing ability to be concerned with the plight of others, to understand others, and to have the bandwidth for people to tell you about their pain and suffering when, as a helper, you don't have any more bandwidth for that. So these are things to look out for in yourselves, in your coworkers, in the people you supervise, and the people that you interact with on a daily basis. And of course, that's important to all of this, right? It's not just about clients or staff. This is humans. So this stuff is helpful when I'm walking down the street and I see someone who's really agitated, or I get on the bus and the bus driver gives me a hard time, right? I'm also looking at those behaviors through this lens and maybe giving people a little bit more slack. So the good news, as I mentioned earlier, is resilience. So just because someone has had a traumatic experience does not mean that they have been traumatized. And resilience is the ability to recover and show early and effective adaptation following a potentially traumatic event. Having positive, consistent, safe adult relationships is really important for building resilience in children, which they can take into adulthood. But importantly, even as adults, our brains are capable of learning and changing. We are able to learn about the issues we've been through, make meaning from them, and then understand our behaviors in a new context in a way that can help us regulate ourselves. So there are a couple of different ways to go about this. So I want to jump into the practical tools here. In providing these services, it's important to remember you do not have to be a therapist to be therapeutic, right? We're not here to diagnose people. We're not here to say, oh, that behavior is a direct result of a traumatic experience that someone had. But we can provide services in a manner that's therapeutic, that's going to help our clients, that's going to help our goals ultimately, because when we provide better services to clients, we're also able to achieve their goals in a more effective way. But it also means that in providing services, we're not making things worse, which is really one of the core principles of trauma-informed care. So SAMHSA has done some great work codifying the work of trauma-informed practices, and this is in relation to what a program or organization would look like if it was trauma-informed. So first, the entire organization would be recognizing and realizing the widespread impact of trauma and understanding potential paths for recovery. Also recognizing the signs and symptoms of trauma in clients. We've been over some, but of course we didn't cover everything today. But that's not just for clients, but also our families and friends, our staff, and others involved with the systems we work in. An organization would respond by fully integrating knowledge about trauma into policies, procedures, and practices. And we're going to talk about that at the end of the presentation today for some ideas about that. But I'll just give you one example. There's a great legal aid organization here in Chicago that they had an unexplained uptick in child molestation cases, and they're an organization that provides orders of protection, and it was really taking a toll on the staff. And so they created a policy that for those cases, there would be 2 advocates on each case. There would be one advocate who was really focused on the family and providing the direct contact, and then the second advocate would be responsible for deadlines and brief writing and the less emotional aspects of the case, and then for other cases they would switch off. So just an idea in terms of how you can shape your organization and policies around these ideas. And then fourth, and this is key to the practical tools, we seek to actively resist re-traumatizing our clients. So the idea is to provide services without making anything worse. And we'll talk about how to do that. So one of the main ideas to start with, though, is to figure out where trauma is in your practice. Is it something you need to know about, or is it something you do not need to know about? And this is key. A lot of people hear about ACEs, and they say, oh, great, we're going to add an ACEs screener. And that's the first thing they do before they've fully trained staff, before they've checked in with staff about their own empathic distress. And so we don't want to do that, right? The point of ACEs is not to find out if people have them. The point of understanding trauma is to provide services in a way that's going to be supportive going forward. And so if you don't need to know about the details of someone's trauma, you should plan accordingly, and you're not going to be screening for that. Of course, there are instances when you need to know exactly what happened, and we'll talk about ways to handle those questions and conversations. But at base, this is the first thing you want to figure out. When do you need to know what has happened? So I've distilled these down into 5 main categories. This is really based on my own work and practical experience. So this is not coming straight from SAMHSA. This isn't really coming from anyone else's academic studies. It's what has been working for me, and I keep refining this this presentation over the last couple of years. I think every time I give it, I make some kind of addition or change. So it's a work in progress. I am not a psychologist. I'm not a neuroscientist. I'm not even an LCSW, which would be amazing to do this work. But I have found that I have better rapport with clients. I have more positive legal outcomes for them because of these 5 tenets. So I start with establishing safety. And you should think about this from the very beginning. So if that's intake or the moment you're engaging with someone, what is the physical environment that they're experiencing? So here at Legal Counsel, when clients enter our space, we have nice lighting, we have some colorful abstract artwork on the walls. When they come into the client interview room, we've got shelving on the walls and plants and uplighting, and we've got normal looking furniture like a wooden desk what we're trying to avoid in our practice is a clinical setting, because we're working with folks with health issues. They're spending a whole lot of time in doctors' offices, clinical settings, and sometimes jails. And so we're trying to make this the opposite of clinical. But we also want people to sit down in a chair where they feel like they can exit the room if they need to, that people aren't going to be coming up behind them, that they have confidentiality. So we have windows here, but we have them covered with an obscuring sort of transparent thing. So all of that is stuff that is important for your clients, but also for yourself as a helper, right? A helper should never be furthest from the door. Helpers should have easy access to leave as well. They should have access to support staff or supervisors in case anything escalates during a meeting. So thinking both about what's going to make your client feel safe and what's going to make your advocate feel safe. Really important here is to be non-judgmental. So we talk in trauma-informed services all the time about not asking what's wrong with you, but asking what happened to you, right? Trying to understand what people have been through and doing that in a non-judgmental way. So one of the things I want to point out here is the change to the passive voice here. And I'll say, as a lawyer, we are always trained to use active voice and to never use the passive voice ever again. But it's actually really important in the way that I talk with clients. So instead of saying, like, why didn't you get James to school last week? He had his special ed evaluation and now it has to be rescheduled. That's a really judgmental way of asking that question. Instead, I'm going to ask mom, hey, what was going on last week that made it hard to get James to school? Right? And then she's going to have some space to tell me what's going on. She's going to trust that I'm not already upset about it or judging her. How we ask questions is really central to all of this. In terms of establishing safety, I like to do a lot of continued assurances. So I mentioned, with teenage clients, many of whom have pretty serious mental health challenges. And for some of those clients, after talking with them and beginning to work with them, I know that for a recent client, I need to shoot her a text message every time I'm going to consult with her therapist. Right? She already signed a release of information. She said it's okay for me to talk to her, but she's going to feel better knowing when I'm talking to her. And that's a 30-second text message that I'm adding to my practice that's making our relationship stronger, which means she's going to trust me more to tell me the important details that I can't that I can't read in the medical records. And security for staff is another issue that I think organizationally we should all spend more time thinking about, whether that's things like having a bed bug policy so that staff know that when they come to work, they're not going to be taking bed bugs home with them, or things like what to do when someone comes in and is really agitated, right? We shouldn't wait until that happens. There should be a plan, and that's going to make staff feel a lot safer. And then finally, previewing what will come. So I do this as often as I possibly can. I'll call a client and I'll say, hey, James, how are you? I have 3 things to talk with you about today. They're X, Y, and Z. What should we start with? And we'll talk about choice in a moment. But I'm always previewing what will come. When we have a special ed meeting, I'm talking that parent and child through everything that I expect to happen in that meeting, from who will be there and how many, to what kind of room it's going to be. For some clients who I can tell are pretty much always agitated, when they come in for a client meeting with me, I'll actually describe our downstairs lobby and the doorman and the elevators and how they get off the elevator on the 9th floor, things like that will set people's mind at ease because they know what to expect and they know what's coming. So being trustworthy, and this is something I think we have a hard time with in the legal profession because we're always a little overworked and a little late, but being predictable is really an important piece of this. And so I've started to try to build my practice and my scheduling in a way that means I can be more reliable for my clients. Establishing clear boundaries is really important. So saying, I'll say to clients, you can call me anytime, day or night, and leave a voicemail, and I return voicemails between 9 and 5 during the day, right? So they know that they can always call me, but they also know that I'm not going to answer after 5 p.m. When you fail, acknowledge it, explain why you failed, and apologize. I think this is something that is really lacking in all of the helping professions. We're doing so much, we're working so hard, and we want to do the right thing. And so a lot of times when we fail, even if I say I'll call you at noon and I don't call at noon, that's a moment when I need to build trust with my client by saying, I'm so sorry I didn't call you at noon. I know I said I would. I had an emergency with another client, and I'm really sorry, and I'm going to try not to do that again. But acknowledging it and building that trust with your client is going to go a long way going forward. Not sugarcoating is really important. I think when people are at their lowest and having their very worst day, a lot of times it's our human reaction to try to look on the bright side or to try to make them feel better. And a lot of what being trauma-informed means is being empathic, recognizing that this is the worst thing that has happened to someone, for instance, and being with them in that moment. There's a really good Brené Brown video on empathy versus sympathy that I always recommend to people. And then finally, keeping promises and not over-promising, right? So right off the bat, I'm never going to tell someone, your case is a slam dunk and we're going to get you X, Y, and Z. In my context, I need to say, I'm hoping we can get X, Y, and Z. It's going to be a tough fight. And that's going to go a long way. I mentioned briefly providing choice. So when I call a client and I preview the 3 things that we need to talk about, the next thing I say is giving them the choice to decide what we're going to talk about. This is also important in terms of goal setting and realizing that people may have different ways to get to a goal, and trying to keep those in mind and keep those as options. Another phrase that we should get rid of on the sugarcoating and glass half full issue, you should never say at least, right? At least you have your health. But also, we shouldn't be saying you have to, right? Autonomy of our clients is super important to building trust. Paternalism has no place in this area. Clients don't have to do anything, right? When I see a client veering off towards a decision that, for instance, is the opposite of why we're working together, right? It's not going to achieve what they said they wanted at the beginning. Instead of saying, you can't do that, or you have to do this, I'm going to say, okay, I know your goal was to get your daughter an IEP. If you make this decision, X is going to happen, and she's very unlikely to get an IEP. So I'll talk through the consequences of the decision, but I'm always leaving the decision-making capacity in my client's hands. And then occasionally passing the push-away test. So I recently was working with a mom whose 10-year-old needed special education services, and every time something went wrong, even if it had nothing to do with me or the case, like the school bus showed up late, and she would call me and she would scream at me, and then she would hang up on me, and then she would text me and she would fire me. And I think a lot of helpers in that situation would say, okay, close the case, right? She fired you, you have too many cases, you have too many people to work with, move on. But I felt great about that case because then 10 minutes later she would text me and she would ask for help. And the conclusion I came to was that she felt safe enough to have all those behaviors and then still ask for help, that I would still help her, that I would say yes, and that we could continue working together. So sometimes when people are trying to end representation or they're waiting for me to fail and they're looking for a reason to end our relationship, I'll say, okay, it's absolutely your right to end this relationship. We have to check in about it one more time. So let's set a date for next week and we'll check in and see if you still feel the same way. So I'm preserving some choice, letting them decide down the road if this is the ultimate decision they want to make. It's important to be collaborative. So I'm asking open-ended questions when I sit down with clients. I'm not interrupting them. I'm not redirecting them very much, especially at the beginning. I'm trying to give them the time and space to share their story. I talked about providing choice. I always frame our work together as a partnership. I'm going to do some things, you're going to do some things, but without you, I can't do anything. Right? We're going to work on this together, and then I outline things that I may need. I may need you to print this out and fax it back to me. I do need you to always answer the, not always, but I need you to answer the phone or return phone calls. Those kinds of things, and saying, I will do the same. If I get a voicemail from you, I'm going to call you back within the next day. So making things equal and partnership-based is really helpful. People always ask me about steering. You know, I'm working with someone, they're telling me their whole life story, and all we need to do is fill out a form. So one way that I try to do that in a collaborative manner is to say, I know the priority for us is X. So in order to do that, you know, here's what we're going to do next. I also preview things in terms of being collaborative. I say, I want to hear your story, but I want to make sure I'm understanding it. So I may interrupt you sometimes to ask you a follow-up question about something that you said. And then you can fill me in on that too. So those are some of the techniques under being collaborative. And then we always try to look to alternative sources. So we're getting school records, we're getting medical records. It's a big part of our practice to have clients signing a release of information right off the bat. This may not work for all of you, right? I know there's a diverse set of efforts going on out there. But think about how you can get information without forcing the person you're working with to talk you through it or re-experience it, right? Because again, we're trying to avoid re-traumatizing. And so if I can read the records and avoid that person having to tell that story for the umpteenth time, then I'm going to do it every time. While we're doing services, we're always trying to empower our clients. So we're trying to build their capacity as we're going forward. We're saying the next time you see this, remember, you're going to do X. So preparing people to handle these issues on their own. I'm always finding things to complement. Of course, I have clients who don't call me back very often or forget to tell me some major thing that happened. And so when those folks are calling me, I'm saying, oh my gosh, I'm so glad you thought to call me. And I think a lot of times in the helping professions, because we're under such pressure and we're trying to move fast, that we don't take those 10 seconds. But those 10 seconds go a long way. Another great way to ask about things like this is to say, how did you do so well in the face of so many challenges? And then really listen to the answer. This is not a rhetorical question. This is a question that's going to give you information about how to empower your client going forward. For me, it's going to tell me what kind of special education planning I want to make for that kid. It's going to tell me who are the people in their life that are going to build them up and hold them steady while we go through what can be a pretty daunting process. And then I remind the client of those things throughout representation. And then finally, providing the tools for success. All the clients I work with are in pretty extreme poverty. So every time I meet someone, I'm giving them a folder that has a small notebook and a pen and my business cards and a brochure about our services. Because they're going to need somewhere to store their documents while we go through this process. I have set up phone calendars with clients who weren't yet using their calendar system, things like that, making sure that folks actually have what they need to get through this process. And then I want to move on to some organizational ideas as we close out here. I mentioned the example of the legal services earlier in terms of sharing cases. Having a crisis protocol for staff can be really useful. Of course, we encounter folks who are dealing with suicidal ideation, and it's going to be really stressful and potentially traumatic for a staff member to deal with that without the tools and the training and the resources that they need. So thinking preemptively about those kinds of issues and how you want people to deal with them in your organization. boundaries with clients could be an organization-wide conversation, right? So that everybody is giving the same answer. Everyone should set up a Google Voice system so that you can text with your clients, but also no one should be giving out my home phone number to clients, right? If we could do organization-wide decision-making like that, it could make things a lot simpler. Organizationally, a lot of us feel like we don't have the time to celebrate even the small successes, but that goes a long way for people feeling fulfilled in their work and resisting burnout. So we're trying to share more positive stories in each of our case acceptance meetings. We're not sharing traumatic stories or details unless it's absolutely necessary. So if I have a case with traumatic details, everyone else doesn't need to know those, right? I may need to talk to my supervisor about it for some particular reason, but I'm not going to share things that other people are going to end up taking home with them. Of course, it's important to disconnect from work. Not everyone is able to do that. Of course, I understand, but figuring out when you can, right? Getting rid of the email on your phone or getting your work calendar turned off of your phone, using those allotted vacation and sick days. I occasionally will use a sick day as a mental health day when we have a lot of really traumatic cases, and I plan ahead and I talk to my supervisor about it, and she's ready for that. So that's an organizational technique that could work for some of you, I hope. It's important to have these kinds of trainings organization-wide, right? The administrative staff are the first person who see clients here. They should have this training. And then finally, health insurance, behavioral health, making sure that people who are providing the help can get the help that they need. I'll mention just a couple of ideas for the supervisor-supervisee relationship. Regular check-ins, right? And I don't mean how are your cases or how many do you have. I mean, how are you? Are you okay? I am not waiting for the people I supervise to tell me that they're not okay. I'm checking in regularly. I'm trying to model good self-care, so I'm trying not to send emails at midnight. Sometimes you're going to have to, work extra hours and put in case notes and things like that. But if there's a way to, for instance, stick your email in your drafts and then send all your emails in the morning when you get to work. Also, not glorifying an unhealthy workload. We tend to do a lot of that in the helping professions. But it doesn't help us do the work, right? And we have to be healthy to do the work. I'm sure you've all heard the phrase, put your oxygen mask on before helping others so that you can help others. And this is all bound up in the same concept. For supervisees, some of the ways to introduce these ideas is to talk about long-term career goals with the aim of avoiding burnout, and get ideas from your supervisor about how to put in some healthy practices to the way you work. Setting boundaries early and often is really important. And then, of course, communicating your needs, right? This is not something to beat around the bush with. Don't use an analogy. Don't use, exaggerated or colorful language. Be really specific. I have too many cases right now. I'm not providing good services in the cases that are most important or that are the most intense. And also, I'm starting to get sick. And if I have sick days, I can't do the work, right? Being very clear with your supervisor about what you need. And then finally, thinking about individual self-care. There are great resources out there on this. It's not a huge portion of this presentation because it's really individual. So one of the things that has worked for me is de-traumatizing with a similar demographic. So I work with a lot of kids who are generally facing pretty serious or complex medical issues. And so I had the chance to substitute teach ballet and hang out with a bunch of kids who probably also have varying disabilities or health challenges. But the point was not to talk about that. The point was to talk about plies and pointing our feet. I know everyone's not going to have a version of that, but it's one way to think creatively about this. There's a ton of great science on the importance and effectiveness of meditation. There are a couple great apps, Happify and Insight Timer. out there for helping you meditate. Exercise is important not just to be healthy, but also to release endorphins and serotonin and to help us combat some of the tough stuff that we see in our work. And of course, sleep and nutrition and therapy, these are the basics. There are great resources out there, and I think some of them are on the available on the website here. So with that, I'd love to hear any questions or have a short conversation about all of this. Thank you all for attending.
Thank you so much, Sarah. Folks, if you have any questions, go ahead and type them in the chat box on the side. I want to be respectful of everyone's time, so we'll get to a couple of them. Sarah, just to start us off, you talk a lot about supporting clients as they face hardships, and in particular, clients in the legal system are facing folks and systems that are very adversarial. So I'm wondering if you have any advice for people as they support clients who are going to be interacting with other people and other systems who are not trauma-informed and who are not particularly concerned with that. And do you have any special advice for those situations?
Yeah, so I rely primarily on previewing and preparing in that scenario and empowering. So if I can help people understand the process that's coming, or if I can tell them, you know, this attorney is going to ask you tough questions and try to trip you up, and here's what they're going to ask. If I can do as much previewing and preparation as possible, I do that. And for clients, you know, every client is different, of course, and so some people are going to want to rehearse, and some people are not going to want to say what they need to say more than one time. So that's a conversation with your client as well. And then I mentioned empowerment, and what I mean by that is saying, I talk to clients a lot about when they should say no, or when they should not take no for an answer, or when they should ask for a supervisor. A lot of my clients will go to a public aid office and be told, no, you don't have Medicaid, and that's it. And I'm always encouraging clients to say, you know, bring their paperwork with them and ask for a supervisor and know when to push and where to push. So of course, it's going to be different for every scenario, but helping people practice for when they need to push back is really helpful.
Yeah, great, thanks. And we have one more question we can get to. We have a question that says, what might a crisis protocol look like for lawyers coming into contact with people who may have acute psychosocial disabilities or mental health issues and are not currently supported?
That is a great question. I don't think a lot of examples exist. I would love to see more of those. So we've been putting together some ideas around this. And for instance, some of the suggestions I made is having a chat box open or a Skype session open on every one of our computers at work. And when I'm in a small client meeting room with someone, my supervisor should know that I'm there and should be ready to intervene if necessary. We also have talked about you know, explaining to clients, I need to go print this so that you can sign it, sort of innocuous excuses to get out of a room if you're in danger yourself. In general, though, it's not part of this practice, it's not part of my advice to people to be the ones to calm things down, right? I am not a licensed mental health person, worker, and so my attitude to, for instance, a really upset client giving me a phone call or showing up really upset at the office is to say, I'm so sorry things are going terribly right now. I really want to help you, but I'm worried about you right now, and I think we should talk tomorrow or later today. And so for me, the priority is really getting out of those situations with everyone, you know, having the opportunity to calm down on their own rather than trying to make that happen myself. But I know, you know, folks even here at Legal Counsel have different ideas about that and certainly different abilities. So there are folks here with more training around mental health first aid and things like that, which also mental health first aid and conversations about suicide is probably an important part of any crisis protocol.
Mm-hmm. Yeah, great. Thank you so much. And folks, I know we're still getting questions rolling in, but we will send a follow-up email to everyone with these questions answered from Sarah. And I am going to share our contact information here. And if you have any questions that you would like us to send along to Sarah, please feel free to send them our way, and we are happy to send them over to her. Thank you so much, Sarah, for this wonderful presentation. I'm sure we all learned a lot. I know I did. And thank you to everyone else for joining us.
Thanks for having me. Take care, everybody.